welcome to this edition of EHC NOW. With me is Dr. Michelle Lavin from RCSI in Dublin. She gave a wonderful talk yesterday on clinical diagnosis of patients with low von Willebrand Factor.
Yeah.
So, first of all, great talk. Really enjoyed it. One of the things that you brought up was discussing the difference between a reduced von Willebrand Factor level and a clinical diagnosis of vWD. A lot of patients get told you have von Willebrand disease, and then they get upgraded almost to a low von Willebrand Factor. And I'm just wondering, how do we go about educating people about what happens in that, or what is the difference between low von Willebrand?
Yes, that's a really great question, because everything changed really in 2008, where it was recognised more and more that if your plasma von Willebrand Factor level was less than 30% of normal, you're more likely to have a cause in your von Willebrand Factor gene that was responsible for that. But those people that were between 30 and 50, where 50 is the cutoff that it becomes normal, so less than 50% is reduced. But people who have a level between 30 and 50, it was felt there was more of a risk for bleeding rather than true von Willebrand disease. But of course, if you've been told for years you have type 1 von Willebrand and now you have low von Willebrand Factor, that didn't mean a lot to patients. And also, it wasn't really clear, did it cause a lot of bleeding, how we manage it, how did you differ from people with type 1 von Willebrand disease? So we set up a study in Ireland, and we're very thankful. There's been a huge support from the patients in the community in Ireland, and looking at the challenges that people who have low von Willebrand Factor that they face in terms of bleeding, and what treatments they've had and how they've responded to it. And from it we got a lot of data, and it showed that patients with low von Willebrand Factor can actually experience quite significant bleeding, and more than we expected to see. But I think what's really important is that if you take the general population and you just decided to take blood samples from people on the street, you'd probably find about 1 in 100 people had low von Willebrand Factor levels. But we only see about 1 in 10,000 people registered with low von Willebrand Factors as a bleeding disorder. So there's probably additional causes of bleeding that we don't yet fully understand that contribute beyond just the low levels in people who have low von Willebrand Factor levels. So they can experience quite significant bleeding, and it differs from the type 1 patients because the levels aren't quite as low and can in fact even increase with age and may increase to a normal level in their 50s and 60s. But we're not again entirely sure if that gets rid of the bleeding tendency, because there could be other things that contribute to the bleeding underlying.
Okay. Well, one of the things that you mentioned was the difference between the bleeding assessment tools.
Yeah, so...
yeah, please.
Well, I'm sorry to interrupt you. I just love talking about
I know,
bleeding assessment tools.
The bleeding assessment tool was very, very interesting, because physicians, what you self-report and what people say is very, very dependent, and yet it does have an impact, and we don't always say it.
Yeah, so the critical thing in the diagnosis of low von Willebrand Factor levels is if you bleed or not, because as I said, you may have low levels, but that may never be a problem for you. So we really have to try and decide and work with patients to determine if they have a tendency to bleed or not, because we don't want to make people get a diagnosis and have another list of the medical conditions, and if it's actually relevant to them and to their future. So bleeding assessment tools are really useful, because instead of just making a list of symptoms like bruising or heavy periods, we can actually objectively assess them using standardized questions to which responses are given graded numbers. So there's between 1 and 4 for every domain, and there's 13 different domains. I like to ask the medical students to list them all off.
Okay.
But it's really the most common problems are nosebleeds, bruising, heavy periods, bleeding after dental extraction, oral cavity bleeding, so bleeding after brushing your teeth, and bleeding after childbirth, and then less common for people to experience things like bleeds into their joints or bleeds into their brain or spinal cord. They wouldn't really happen in patients with von Willebrand disease, but they're included in the questionnaires. Yeah. But there's the two most common questionnaires, and these questionnaires have only been around for 13 years. That's when the first questionnaires came about, and they've really evolved over time to make them more streamlined, so there's less questions for patients to answer, but you can still get a composite result. And the two most common questionnaires are a rather unfortunately named for my presentation, the condensed MCMDM 1vWD score, which is quite a mouthful, but and then the ISTH BAT, which is the ISTH bleeding assessment tool. And both are commonly used in the assessment of people with low BWF and Willebrand disease. But in fact, what we found is that the condensed score doesn't work as well for menorrhagia. And when we looked into that, we found really significant differences. So the same patient, the same information, some people were scoring 0 using the condensed score for that bleeding domain, and some were scoring 3 out of a maximum 4. So there's a big difference there. And it actually came down to, did you go to your doctor and tell them you had heavy bleeding? Because if you never reported to your doctor, you got 0 using the condensed score. Whereas if you had heavy periods since your very first period and had heavy periods for the last 12 months, you get a score of 3. Or if you had clots and flooding, or changing your pads more frequently than every 2 hours, or if you had needed time off work or school, you can get scores using the ISTH-VAT. So it doesn't take into account, some of the questionnaires don't take into account the patient-reported symptoms that they're living with and maybe not recognizing as abnormal.